My name is Dean Drosnes, and I am an addiction medicine physician. I practice at Caron Treatment Center. For those of you who don't know, Caron is a residential treatment center in Warnersville, Pennsylvania. It's been around for about 60 years. They were kind of one of the original cadre of 12-step oriented Minnesota model treatment areas, and they've grown and matured over the last number of years. My background, well, let me do some formalities here before I do that. So I am employed by Caron Treatment Center. I have no financial interest in any companies or products or anything. I'm a practitioner getting a salary through Caron. And I put this slide in for one of my colleagues who told me he was going to be here and then bailed out at the last minute. And he was telling me, oh, you need to put all these really fancy graphics and all these pictures and make it really interesting. And I tried doing that and I failed miserably. So I put this slide in just to appease him. And he's not even here to look at it, so it's his loss, right? So no fancy graphics, just information. All right, yes, and here it is late in the afternoon, and if you're bored like this guy, and you have not yet painted the top of your head and cut your hair in that regard, you have a couple of options. You can leave, that's fine, I won't be offended. I don't take things like that personally. You can use your tablet or phone. You know, when I was in college, if I'd had a tablet or phone that I could play with during boring lectures, it would have been golden. It wasn't around back then. You can take a nap, and that's okay. Or you can, like, look at this, right? And isn't that cool? That's very good. I was reading the other day that the average person's attention span in a lecture is 7 minutes. 7 minutes. So what I can do, I can flash this slide every 7 minutes and then you can look at it, but maybe you should just take a nap at any rate. So just to give you, and I'll let you stare at this while I give you my background, just to give you my background. I trained in ear, nose, and throat head and neck surgery many years ago and practiced that for about 15 years. And as a consequence of that, I, number one, saw tons of people that had addiction, in addition to their head and neck cancer that came from their chronic years of smoking and drinking. I also saw a lot of people that had chronic pain conditions, TMJ, sinus problems, chronic headaches, migraines, atypical facial pain, you name it. And in 2009, I made a choice to go back and retrain in addictions. I went to the University of Maryland Medical Center, did an ABAM training program in addiction medicine, and I really just thought I could be more helpful in this regard than I was doing what I was doing. And I remember one of my mentors, who was a social worker, had been doing this since the 1970s, said to me one day, we were in a consult liaison service in the hospital, and we're seeing patients. And we go into a patient's room, and he tells me a little bit about the patient. She is a 34-year-old woman. She weighs about 450 pounds. She's a diabetic, never in good control. She's also on methadone maintenance for her chronic heroin addiction. And she has chronic pain that makes her disabled. And, you know, she can barely care for her children. She can't work and all this. And he says to me, as I'm a trainee, I'm in training for a couple of months, he says, now, this is the kind of patient that if you can help, you'll be doing a service. And I took a step back and I was like, are you kidding me? And that's what I'm thinking to myself. Are you kidding me? What can you do for somebody like this? She's so sick and she has chronic pain, and what are we going to do for her? And that patient stuck with me as I finished my training, and I went to work at Caron Treatment Centers. And I thought about, you know, what do you do for somebody who has a substance use disorder and chronic pain at the same time? What the heck can we do for somebody like that? And it became kind of an obsession for me. I didn't want to do that work because I was like, these are the toughest patients. At this stage in my career, I don't need the toughest patients. When I was 25 or 30, that's okay, but not now. But those patients need the most help. So, they're very compelling, and I found myself drawn more and more into this. And I didn't ask to be doing chronic pain management in people with addiction, but that's what I do. And I love it. I won't lie about that. Who here saw Dr. Jacobs during the lunchtime? Did anybody not see that? Anybody not see Dr. Jacobs? Darn. I was hoping that y'all, because... Well, he did so much of my work for me. I just have to say that if you saw his talk, this talk, it's like a perfect segue from his talk to what I'm going to talk about today. And just to very briefly, Dr. Jacobs reviewed the history of opioid use for chronic pain, starting from its inception back in the, for non-cancer pain back in the 90s to the, swelling of problems, and now the recognition of, oh my gosh, there's too much opiates out there and they're really not very good. And he ended his session with the CDC guidelines for the use of opioids for chronic pain. And after a few introductory slides, I'm going to start with some of those same guidelines, and we did not coordinate this. Let me move on. So let me just tell you what I hope you'll be able to glean from today's talk. So here are the educational objectives. Number one, if we can talk about the factors that contribute to a recovering person's need for an individualized, multimodality, recovery-compatible plan for treating their pain, okay? But be able to describe what are the medication needs of somebody who's in recovery, and compare that with people who don't have the disease of addiction in terms of what their meds are. 12-step principles, applying 12-step principles to recovery from chronic pain and incorporate step work into the treatment regimen. Demonstrate the use of an integrated multi-specialty team model for treating coexisting addiction and chronic pain, and I'm fortunate enough to come from an institution where I have that model available to me. And talk about specific case studies of this approach, its implementation and results. So when I talk about topics, pretty much any topic, I like to use case discussions as a way of talking about it because they make it more real. It's kind of like, what are you going to do with this person? So I'm going to start with a case. Case number one is a 16-year-old girl. She has an impacted lower third molar, and she goes to the oral surgeon, and they do an extraction in the office. They give her a little nitrous. She breathes it down. They take out this wisdom tooth. Everything goes just fine. And she's getting ready to leave. And they prescribe her 30 oxycodone with APAP. 30, right, for this uncomplicated procedure. Okay? This is very typical, by the way, in case you don't know that. If you have kids of wisdom tooth extraction age, you might know that. Her mother is an RN. Her mother is an RN that I've worked with for many years, and we discussed this case. And she said to me, I told the pharmacist, please only give me 5 of these Percocet tablets. I don't need 30. And I didn't know before she told me this that we all have a right to do that. If somebody prescribes you 30 pills of whatever and you only want 3, like this, a PRN pain medication, you can just ask the pharmacist, just give me 3. I don't want the rest. So that's what she did. But the pharmacist said, no, please take the 30, because he makes a bigger sale, right, if he prescribes the 30. And then, the doctor doesn't get called if the person runs out of pain medication. And what I can tell you is that following a discussion between this nurse friend of mine and the pharmacist, she got her 5 tablets. Her daughter took 2 of those 5 tablets, and she flushed the rest down the toilet. It's an ideal situation. It's kind of like that's the way it's supposed to happen, but that's not how it usually happens. And, those of us who do addiction medicine, we look at this kind of scenario, and I heard a couple people kind of, groan when they saw that this young girl gets a prescription for 30 Percocet tablets after a wisdom tooth. And those of us who are aware of what kind of problems this have, this is part of our philosophy. This is called addiction medicine logic, right? If you're those of you who've ever studied logic, you know that logic has what are called if-then statements, right? If you have a bottle of oxycodone, right, then you will have kids with their hands in the cookie jar, and you will have other kids jumping for joy. And there's plenty of statistics and data to back this up. Most kids who start using opiates get it from prescriptions given to their friends, where they have leftovers, or they get it from their parents, or they get it from the medicine cabinet, okay? And this is how it starts. So I want to talk about pain, but I'm going to talk specifically about chronic pain, all right? Chronic pain and acute pain, for those of you who saw Dr. Jacobs, they're two different animals. Opioids are excellent medicines for treating acute pain. Acute appendicitis, I fall down right now and break my ankle, opioids are the right medicine. But for chronic pain, one of the things I'm going to talk about is how we have this information that says they're not the right medication, and then what we can do as an alternative. So the first statement I want to make is chronic pain is common. It's a very common condition. There's a lot of references that cite that pain is the most common reason that people go to their physician or go to the emergency room or go to an urgent care centers because they're having some kind of pain. All right? American Pain Society says there are up to 100 million people in this country who have chronic pain. That number is debatable. It depends on where what sources you're using. Nevertheless, that's a lot. And anywhere between 3 and 30% of those people with chronic pain have a substance use problem. That's a lot of people, okay? And pain is a leading cause of long-term disability, and it's a major contributor to healthcare costs. So this all falls under the category of public health information, right? This is large populations of people, and I just want to point that out, and I'll get back to that in a minute. So my second assertion is this: chronic pain is inadequately treated. For the most part, we do not a very good job of treating pain, okay? Chronic pain. None of the currently available treatments for chronic pain eliminates pain. And you know, if you ask doctors and if you ask patients, what's the goal? They'll say, well, to have no pain. And you know, when I see patients that come in, what's your goal for your pain? And periodically, give me a 0 to 10. We use that 0 to 10 Likert scale on a regular basis. On a 0 to 10 scale, what's your goal for your pain? 0 pain. And sometimes I look at them and I say, you know, you're over 50. The chances of you having 0 pain after age 50 are pretty small. If you're paying attention, you're going to know something's bugging you somewhere. But people expect elimination of pain, and providers expect elimination of pain, and no medicines or treatments cause elimination of pain. We use opioids, and Dr. Jacobs talked about this at length, and we use opioids for treating non-cancer pain based on their efficacy for treating cancer pain. That's what these drugs were used for. End-of-life care. People who did not, you know, the idea of treating somebody at the end of their life is to enable them to have some kind of dignity and some degree of comfort as they're living out their final days. To have them have relationships with their family, to put their affairs in order, right? You don't ever have to worry about getting people off of these medications, and it was appropriate. Same with the HIV patients that were spoken about earlier. When everybody that had a diagnosis of HIV was going to die, it was reasonable to put these people on opioids and keep them comfortable. And there were trials showing that these opioids help people with cancer pain. Good studies, you know, randomized controlled trials up to 12 weeks in length, but there were no chronic, you know, studies more than 12 weeks in length. And opioid use in acute pain settings is traditional. People have known since, you know, they were grinding up poppy plants and, putting it under people's tongues and when they had an injury that it works. And there's never been any studies, any scientific studies showing, because it wasn't necessary. Before, opioids were used for acute pain before the standard by the FDA was to do studies to make sure that it works. So it's traditional. All right. And there's terrible data for chronic non-cancer pain. The use is based on studies that find what they call clinically meaningful pain reduction. That's a 30% reduction in pain. If somebody says, yeah, my pain's down by 30% of what it was, that's called clinically meaningful. And we'll get back to some of this as I review the CDC data. My third assertion is this: chronic pain is over-medicated. This is what we rely on for treatment of pain. In 2012, there were 259 million opioid prescriptions written in the United States. 259 million. That's a lot. And this is very commonly quoted. I've heard this probably 4 times since I've been here. We make up, in the United States, 4.5% of the world's population. We use 80% of the opioids in the world and 99% of the hydrocodone in the world. We're a hurting country, we hurt, I don't think we hurt any more than anybody else in the world does. We just expect that the treatment for pain is to use drugs, and opioids in particular. That's our expectation. We've grown up with that. So the treatment as usual, as I like to call it, for chronic pain is medications almost always. We focus on the biological component of pain. And I'm going to talk about the different dimensions of pain throughout this talk. But the biological component, how is that knee feeling? You tore your meniscus. How's that knee feeling? How's your lower back? Right? The biological component of pain. We over-rely on medication, and the reason why is because it doesn't take long to just write a prescription and and it doesn't cost as much for somebody to just stay on medication as it does to go get physical therapy, to go to the pool and go swimming. It's not as expensive monetarily, it's not as expensive with time. So this is cheap and simple. Okay, this is why we do it. But it causes an inadequate relief. It doesn't give people what they need. And the reason why it doesn't give people what they need is because there are multiple components that go into people being uncomfortable when they have a chronic pain condition. And it also doesn't restore function very well. My number one goal when I treat a chronic pain patient is to restore function. Let's get them at their maximum level of function in life. Now that for some people may be going out, working 8-hour days, interacting with their kids, sports activities, everything. But for other people, that's not realistic at all. But they're at least off the couch. They're doing something. They're interacting with other people. They're living a life, so to speak. The population of patients that I treat have both chronic pain and addiction. So I'm very, I feel I'm fortunate because this is not a one-size-fits-all prescription for treating pain. But for people who have substance use disorders and chronic pain, this is what's called double trouble, all right? What happens is that people who have a substance use disorder experience greater levels of pain from the same physical injury than somebody that doesn't. They have physical as well as emotional pain, and that's a very, very important aspect of pain, both from a practical standpoint and from a neuroscience standpoint. They have much greater difficulty with withdrawal from medications. In the past 2 months, I have talked to 2 people that I know personally who do not have a substance use disorder. Both had acute injuries and were put on opioid painkillers for 3 weeks. And both of them called me and said, I had such terrible withdrawal after 3 weeks of being... I had no appetite, I had diarrhea, I couldn't sleep at night, I was achy, nauseous. I had withdrawal, right? And if you have a substance use disorder and you have withdrawal, it's much worse and your pain gets worse, okay, if you have both. And there's a much higher relapse risk for somebody in recovery who has a chronic pain condition. I think it's the #1 risk for relapse to opioids is having a chronic pain condition, if somebody is able to maintain abstinence from opioids. So, as I mentioned, I want to talk about some of the CDC guidelines. Dr. Jacobs went through the guidelines themselves at the end of his talk. And what I'm going to talk about is not so much what the guidelines say, but the evidence that they based these guidelines on. This was a 60-some page paper that they published, and it's really boring for the most part, but there's some very important stuff in there that I want to highlight. So basically what they're saying is no study of opioid therapy versus placebo, no opioids or non-opioid therapy for chronic pain evaluated long-term outcomes. It's never been looked at. What happens after a year? Nobody's ever looked at it. And not only that, but they didn't look at pain, they didn't look at function, they didn't look at quality of life. The trials were usually less than 6 weeks. Well, that's not very chronic, right? Chronic pain is 3 to 6 months. So what's the conclusion? The body of evidence for long-term opioid use for chronic pain is insufficient. The CDC said that. It's insufficient. We don't have any data. Okay? Next, factors associated with increased misuse include history of substance use disorder, younger age, major depression, and use of psychotropic medications. Well, that's almost everybody I see fits into that category at some area, and my presumption is that you are all doing addiction treatment provision in some aspects, so these are the people you see too. In 2014, the Agency for Healthcare Research and Quality report found insufficient evidence from 3 open-label trials to determine comparative effectiveness of long-acting opioids versus immediate-release opioids for titrating patients to stable pain control. Now, one of the things that I was taught way back when was that, well, short-acting opioids, the onset is quicker, and it's more powerful. So the person who's prone to addiction likes that more. So therefore, you should use a long-acting, slower release opioid. This is why OxyContin became so popular. Oh, it's slow release. It doesn't activate that reward system. It's very safe, right? But this data says they've never compared them. One fair quality cohort, fair quality at the VA, showed initiation therapy with a long-acting opioid was associated with a greater risk of overdose than immediate. So it's completely 180 degrees from what we were taught years ago, okay? No study evaluated the effect, and this is, so what happened is that there were all these recommendations. You got to do these treatment agreements, you have to do urine drug screens, you got to do monitoring, and all the stuff that we all do. No study ever looked at whether these are helpful. Abuse deterrent formulations, pill counts, all the stuff that we do, that makes sense. So they make sense, but nobody's ever looked at to see whether that actually helps. Now here's what they did find. Several non-pharmacologic and non-opioid pharmacologic treatments are effective in managing chronic pain in studies for 2 weeks to 6 months. 6 months, that's chronic pain, 6 months, right? That's the cutoff point. So there is some evidence. What are these things like CBT, cognitive behavioral therapy, exercise therapy, combination therapies where people are using multiple ways of dealing with these pains. So this stuff works. In non-opioid pharmacology, things like Tylenol and non-steroidal agents and topical agents and all these things that kind of, play second fiddle, so to speak, to the Percocet and all that stuff. These things actually work from studies. So in summary, the evidence that go into the CDC guidelines shows this. No evidence for a long-term benefit of opioids in pain and function versus no opioids. We said that already. Extensive evidence showing the possible harms of using long-term opioid therapy, including overdoses, motor vehicle injuries, addiction. and extensive evidence suggesting some benefits of non-opioid pain treatment with less harm. So it's pretty clear what they're saying here. It's pretty clear what they're saying here, all right? Because pain management is so complex, clinicians should consider consulting a addiction specialist and pain specialist, okay? So that's what we're stuck with, and we've been doing this for a long period of time using opioids. Now, the other triumvirate that was mentioned at lunchtime today was the combination of opioids plus Soma plus Xanax, and the other one that I see a lot is, well, you know, you're so sedated from all these other drugs you have, we better give you some Adderall in the day so you can stay awake. That one's another one that I see all the time too. I fall asleep at my desk. Oh, well, you better have a stimulant. Yeah, that's helpful. Anyway, these medications, you know, if you look at studies of these medications in pain, zero evidence of effectiveness, lots of evidence of harm. So all the benzodiazepines, they have no place in the treatment of chronic pain. What happens is people come in to their doctor and they say, this keeps me awake at night, I can't sleep. The doctor says, oh, well, let me give you something for sleep here, right? That's the benzodiazepines and the hypnotics. Muscle relaxants for muscle spasm associated with chronic pain. These medications are used. Barbiturates are still in the preparations that are used here, Furoset and Furanol, for migraine headaches, very common. And then again, the stimulants, as I mentioned. So these are all abusable drugs. They should not be part of the regimen. So this is one of my favorite things. What is pain, right? The definition of pain is right here. It's an unpleasant sensory and emotional experience associated with actual or potential tissue damage. That's the definition of pain. Now let's dig into that a little bit. It's an unpleasant experience. That's the most important thing. It's an unpleasant experience. Breaking your leg is an unpleasant experience if you've ever broken your leg. It's very unpleasant. Having a promise broken is also a very unpleasant experience. Somebody promises you something, doesn't follow through, that's a very unpleasant experience. And a broken heart is also a very unpleasant experience. But if this is the definition, why do we call this pain and we don't call these pain? Question for thought. So how can we treat pain appropriately? If we're going to treat pain appropriately, how do we do that? Well, we have to address the unpleasant experience. And the unpleasant experience is not just the kneecap or the low back or the headache. It's the whole unpleasant experience. There's a biological component to chronic pain. And that, you know, this has to do with all of the medical stuff, and I don't want to get into this in too much detail except to say, you know, we know there is nociceptive pain where the pain receptors transmit these signals through the nervous system and up into the brain, and then the brain processes it and decides if it's good or bad or indifferent. And there's neuropathic pain, long-term pain from certain conditions causing this feedback loop of pain signals. And then there's these hypersensitization syndromes of pain, right? Things like fibromyalgia and Lyme disease-related chronic pain, et cetera, et cetera. And those are all biological components of pain. But there's the psychological component. And the psychological component is this. It distracts us from doing what we want to do. Anybody who has had an acute injury with acute pain knows this. You know, I'm trying to read this book, but this thing's throbbing, and it just won't leave me alone. I'm distracted. I can't pay attention to my kids. Our focus becomes on the pain, which tends to magnify it, right? We can't concentrate very well, and then we can't sleep. So significant psychological manifestations of pain. There's an emotional component. It's the anxiety. Oh my gosh, it's going to be cold and damp today. What the heck's going to happen to me? Because when it gets cold and damp, my pain gets way worse, right? And then there's this anger. It's like, God, this has been going on for 3 years now. I'm not getting better. I can't stand it anymore. I keep going to the doctors. They're not helping me. People are angry. Chronic pain always, in some degree or another, causes depression. Always, in every case. If you have pain for more than 6 months, I guarantee you're going to be depressed. There's no question about it. It happens with every patient. And people are frustrated because they're trying everything under the sun, And they're going to their doctors and they're saying, well, doc, it's really not taking the pain away. And the doc says, oh, well, just take more. No, it's not working, so you're telling me to do more of it. Something wrong with there. So emotional component is huge. Then there's the sociologic component, which is the, hey, do you want to go to the movies? I don't think I can sit that long. Do you want to go bowling? Oh my God, I can't go bowling. Do you want to, people just so then they become isolated. They're homebound. They're lonely. They're not very useful. They can't help other people, right? They have to ask for help. And it just feels terrible. And then there's the spiritual dimension. And that's the suffering component. And that's where people are isolated. They're resistant to move. They just want to sit on the couch and, be a couch potato, watch TV, read books, eat bonbons, whatever they're doing. They feel threatened, they give up. This is very akin to what people experience when they have late-stage addiction, right? They have this spiritual suffering. They're miserable. So it's interesting because if you get really into the neuroscience of chronic pain, it's very similar to the neuroscience of addiction in terms of the brain areas that are involved. And chronic pain, there have been studies looking at what happens to the brain in people who have chronic pain acutely, in other words, a month or two, and then what happens to them a year later. And they can actually predict, this is a group in Northwestern, Dr. Apkarian and his group, they can look at brain scans and predict which of the patients at 1 month or 3 months will have pain in a year and which ones won't because of which brain regions are activated.